Dear colleagues, now I want to give you a presentation about an exotic cancer type, the neuroendocrine breast cancer, and various aspects of comprehensive tumor profiling in focusing on PI3K-mTOR pathway. It's a rare entity accounting for less than 0.1% of all breast carcinomas and 1% of all neuroendocrine tumors. Diagnosis of NEBC is often challenging as other neuroendocrine tumors, but also lung, gastrointestinal, and pancreatic cancers as primary extramammary tumors need to be excluded. Generally, morphology remains the base of pathologic classification, but NEBC do not exhibit a definite and unequivocally recognizable morphology, so diagnosis often relies on immunocytochemistry staining for chromogranin A and synaptophasing, which are also sometimes expressed in other non-neuroendocrine tumors. Adjunctive staining, for example, of mammaglobin, Gator3 and GCDFP15 allows to confirm memory origin. While above-mentioned immunocytochemistry staining is not conducted routinely, it's difficult to evaluate the real incidence of NEBC. Observation shows a neuroendocrine differentiation in up to 20% of all breast cancers. It's inconsistent to the fact that NEBC are diagnosed in less than 0.1% of all breast carcinomas, based on the latest WHA classification in 2019. Due to low prevalence of these tumors and successive changes in their diagnostic criteria over the years, no therapeutic guidelines have been established to date. In most cases, treatment strategies in NEBC are empirical, an absence of prospective trial data on NEBC cohorts. NEBC are mostly associated with poor long-term survival and with rapid therapy resistance development. It's known that surgical intervention is currently the mainstay of therapeutic approach. Systemic treatment strategies are generally chosen depending on clinical pathological features like TNM status and aggressiveness of tumor, age and comorbidity of patient. If curative chemotherapy is necessary, NEBC has been treated analog to adenocarcinomas of the breast or small cell lung cancers. But what is tipping the scales? So, for gastrointestinal neuroendocrine carcinomas, the proliferation index Ka67 has been used to predict clinical behavior, and a value greater than 15% is associated with early metastasis and poor long-term survival. Due to lacking recommendation, it seems to be reasonable to use this proliferation index as an indicator for choice of chemotherapy regimen, as in other neuroendocrine carcinomas. The combination of surgery, radio and chemotherapy showed promising results, but there are no guidelines for staging and therapy, nor in the early stages, neither in the metastatic setting, so it leaves the treating oncologist to opt for suitable systemic treatments. Nowadays, development of tumor profiling provides the opportunity for individual precision therapies to evaluate targetable genetic alterations respecting involved activation and inhibition of signal transduction pathways. This tool is useful for rare tumors without existing therapy guidelines and for tumors refractory to prior therapy. It offers the possibility to match the right drug to the patient to improve patient's outcome. I want to illustrate the therapeutic challenges presenting the EP crisis of following two patients. The first patient was a 67-year-old female diagnosed with NEBC of small cell subtypes. Undergoing surgery and considering definite tumor stage, there was an indication for adjuvant chemotherapy. It was tailored to high proliferation index of 60%, so she received 6 cycles of carboplatin etoposide, followed by radiotherapy of the breast, but not of the brain. Only 17 months after completing adjuvant treatment, a solitary brain metastasis was detected and extirpated. Considering micrometastasis in the brain, topotecan was applied due to its ability to cross the blood-brain barrier. But therapy failed. A little bit later, metastases in the lung and the pleura were seen. So it was an aggressive scenario, a high-grade, highly proliferating tumor, and at this moment no appropriate clinical trials were available. We wanted to change treatment strategy, more focusing on neuroendocrine characteristics. So we proposed dotatate-based PET-CT with possibly following peptide receptor radionuclide therapy as an experimental diagnostic and therapeutic alternative. Somatostatin receptor expression is mainly considered a feature of well-differentiated gastrointestinal neuroendocrine tumors. But this aggressive scenario raises a provocative question of indication for dotatate-based PET-CT. Nabe and colleagues found positive correlation between SSTR expression in the midgut and hindgut, 2 grading, and Ka67. In NEBC, this correlation is unknown, but one case reported by Cervelli and colleagues showed promising efficacy of radioligand therapy in NEBC. However, this proposal was rejected by the patient herself, and an individual approach was necessary. Tumor profiling was performed by Exacta using peripheral blood cells to detect targetable genetic alterations by NGS, gene expression profiles, further targets determined by immunocytochemistry staining, pharmacogenetics of tumor-specific medication, and CTX sensitivity testing using circulating tumor cells. So NGS revealed an activating mutation of the PI3K, which is part of the PI3CA-mTOR pathway. It's important for proliferation, migration, cell survival, and tumor metabolism. It's observed quite frequent in neuroendocrine tumors. Information about incidence and clinical impact in NEBC is inconsistent. It suggests therapeutic benefit from mTOR or PI3K inhibition across different cancer types. Due to extended metastasis and high proliferation index, gemcitabine and oxaliplatin, based on chemosensitivity testing, together with mTOR inhibitor temsirolimus, were applied. This therapy was tailored to individual tumor characteristics, but no response was seen despite molecular evidence and CTX testing. Why did this precise therapy fail? NGS revealed PI3K mutation as the only targetable alteration, but further information about this important pathway would be necessary. Are there any predictive factors? First, there's this activating mutations just mentioned, and further possible predictive factors concerning inhibition of PI3K like PTEN loss, KRAS, P53 mutation, FGFR1 and 2 amplifications. In fact, they are under exploration. In case of our patient, molecular tumor profiling did not reveal any of the above-mentioned alterations. But gene alterations do not always implicate adequate gene expression. So the next step towards this evaluation was to consider special messenger RNA levels. And we had a look at individual peripheral effector mechanism. This simplified graph illustrated the branches of PI3K pathway. And the above sheet reflects peripheral parameters of mTOR pathway, which were downregulated For example, RAP as a direct activator of mTOR, or even more peripheral, ribosomal protein 6, which is mainly affected by temsirolimus, or eukaryotic initiation factor 4b. So in retrospect, what did we do? It could be hypothesized that we inhibited a just downregulated pathway. It appeared that the proliferation-promoting influence was not mainly triggered by mTOR. This was not predictable, focusing only on molecular base. We wanted to focus therapy on the only targetable alteration. So we had a look to the other branches of PI3K pathway. And it seemed that alpelisib as a direct inhibitor of PI3K would not suffice to inhibit the whole pathway to a large extent. And this assumption could be assumed by the fact that important branches of PI3K, like tumor metabolism, cell cycle progression, and cell survival, weren't upregulated on messenger RNA base. To address this issue that many decisive components of PI3K pathway weren't upregulated, in taking into account a high proliferation rate, a cytotoxic agent based on carboplatin was administered, analog to this study, in combination with alpelisib. For the first time, a remarkable therapeutic effect was seen. Oxygenation improved significantly, and patients changed from ECOG 2 to ECOG 0 within 3 weeks. Imaging showed no more pleural effusion, and it looked like a first wave in the right direction. But 7 weeks later, she suffered from an etiologically unclear thoracic pain with sudden death. We wanted to arrange for an autopsy, but it wasn't possible. The second patient was a 51-year-old female diagnosed with NEBC of large cell subtype, undergoing surgery, and considering definite tumor stage, there was also an indication for adjuvant chemotherapy. And it was tailored to high proliferation index of 40%, so she received also 6 cycles of carboplatin etoposide, followed by radiotherapy of the breast. Shortly after completing adjuvant therapy, only 1 month later, liver metastases were detected, and a planned atypical liver resection was rejected due to intraoperatively diagnosed diffuse spread also into the left lobe. From liver biopsy resulted a highly proliferating metastasis, poorly differentiated, deriving from known NEBC. So it was a threatening situation. Tumor profiling using exacta analysis based on liver tissue and blood was performed to adapt tumor-specific therapy exactly to tumor's characteristics. Waiting for results for 2 weeks, diffuse bone metastasis and infiltration of spinal canal developed, and radiotherapy was applied. Following alterations with certain clinical impact resulted from tumor profiling. First, there was an STK11 mutation, which are reported in neuroendocrine carcinomas such as large cell subtypes, but rare in breast cancer. Exactly this mutation is characterized as a loss of function mutation, which can lead to activation of mTOR. It's associated with lack of PD-L1 expression. In fact, no PD-L1 expression was seen. MSI stable, low tumor burden. So it was not suggestive for benefit from checkpoint inhibitors. A second mutation, this TP53 mutation, is associated with functional loss of p53 activity, which can additionally contribute to activation of PI3K-mTOR pathway. Furthermore, there's mounting clinical evidence that emphasizes the importance of TP53 mutations in predicting response to anti-angiogenetic therapy. Preclinical and clinical data demonstrate that loss of function mutations of TP53 induce higher level of vascular endothelial growth factor A and hypoxia-induced factor alpha, as it is revealed in this patient. Messenger RNA-based pathway modeling shows increased signaling of angiogenetic parameters together with positive immunocytochemistry staining for vascular endothelial growth factor A. Furthermore, NGS revealed an amplification of FGFR1 and FGFR2, so it might hyperactivate PI3CA-mTOR pathway and partially MAP kinase pathway. Especially FGFR1 amplification is associated with resistance to endocrine therapy and PI3K inhibitors, while retaining efficacy to mTOR inhibition. In the synopsis of all molecular genetic findings, it seems to be promising to applicate an mTOR inhibitor. Due to prior experience with molecular genetic analysis, we further evaluated the mTOR effect on protein synthesis, looking at peripheral effectors at messenger RNA level. Ribosomal protein 6 kinase 1 and 2 were overexpressed, stimulating protein synthesis by eukaryotic initiation factor 4b and ribosomal protein 6. Consequently, mTOR inhibitor everolimus was applied. But mTOR inhibition as monotherapy? I want to give you some reflections about this issue. Everolimus, as an allosteric inhibitor of mTORC1, seems to affect mainly mTORC1 substrates, such as ribosomal protein 6, rather than stronger factors like eukaryotic initiation factor 4b. Consequently, mTORC1-mediated protein synthesis could only incompletely be inhibited. It can lead to potential suppression of negative feedback loops, for example, increased IRS1, which activates PI3K-AKT pathway. Downregulation of ribosomal protein 6 affected by everolimus can in turn lead to AKT activation, and interconnected pathways like MAP kinase pathway may be stimulated. So, inhibition of one parameter of PI3K-mTOR pathway could provoke stimulation at another level. An advantage of mTOR inhibition in combination with anti-angiogenetic therapy could be promising because hypoxia-induced factor alpha and VEGF-A pathways, so-called angiogenetic pathways, were upregulated, so bevacizumab was added to everolimus. Due to highly proliferating disease with extant metastasis, the cytotoxic substance capecitabine was administered according to chemosensitivity testing. And this combination was well tolerated. She expressed high quality of life, and we reached stable disease for 3 months. But later, tumor progressed dramatically, and patient died due to liver insufficiency. Behavior of tumors is characterized by a myriad of mechanisms. Each factor influences processes of survival and proliferation, singularly and cumulatively. This complex context illustrates the advantage of evaluation of tumor-specific targetable characteristics based on above-mentioned components. This comprehensive tool was used in 2 patients suffering from a highly aggressive cancer type after failing of empirical therapies in analogy to recommendations for breast cancer and neuroendocrine carcinomas. Especially in rare cancers with bad prognosis just from the beginning, we should consider tailored therapy earlier to prove that extensive diagnostic and therapeutic approach could provide a benefit. Currently, tumor profiling delivers advantages only to a minority of patients. Newer trials showed beneficial outcomes even in late-stage patients with several previous therapies, applying enhanced molecular analysis comprising also cytological features and other cancer characteristics. More data are existing which demonstrate that matched patients versus unmatched patients had higher rates of long stable disease and longer PFS. Higher matching score is correlated with longer PFS, as it is demonstrated in the Winter trial. Combining genomic and transcriptional profiling is useful to improve personalized treatment recommendations and subsequently patient outcome. If possible, not only targets may be considered for choice of therapy, but also the context of the whole pathway network together with biomarkers. Bridging to a further outlook, we have to extend the diagnostic tool to the metabolome. Napstead and colleagues could show in vitro that tumor cells resistant to PI3K-mTOR inhibition differ with regard to metabolic profile compared to sensitive cells. But no single metabolite identified responders from non-responders. This possible importance of various metabolites should be considered when future clinical studies, for example based on mTOR inhibition and combined therapy, are planned and analyzed. This is only one example for new fields of interest to develop novel therapeutic strategies. I want to conclude my presentation with Goethe. Every solution to a problem is a new problem, but I want to add which is being solved again. Thank you for your attention.